All right, this briefing will cover the new expert consensus on procedural standards for X-ray-guided breast localization and biopsy. Our goal here is clear: standardize these operations to sharpen diagnostic accuracy and, of course, improve procedural safety.
Okay, let's start with the most critical part, the decision-making framework. We'll be looking at the specific indications and contraindications that drive patient selection.
So, looking at our indications. For biopsy, you're primarily targeting BI-RADS 4 and 5 lesions, along with some select BI-RADS 3 microcalcifications. For pre-surgical wire localization, we're talking about non-palpable BI-RADS 4 and 5 lesions, or cases with multifocal disease that need to be excised together. Now, on the other side of the coin, the contraindications. The absolute ones are non-negotiable. Severe coagulopathy, a local infection, or significant systemic disease. Think NYHA class 4 heart failure. Then you've got your relative contraindications. These require real clinical judgment. We're talking about things like pregnancy, poor tolerance to compression, and tricky lesions right up against the chest wall, especially when the breast thickness is under 3 centimeters.
Next up, technique selection. How do we choose the right tool for the job? It really all comes down to the lesion's characteristics and how well you can see it on prior imaging. Let's compare stereotactic, DBT, and CEM. Okay, let's break this down. Stereotactic localization is your established workhorse, the standard for those clear, non-superimposed lesions. But what if you're dealing with dense or overlapping tissue? That's where DDT, or tomosynthesis, really shines. It's superior because it cuts right through that superposition. And then there's CEM. This is your problem solver for lesions that are practically invisible on standard imaging but light up with significant enhancement. Here, you're leveraging physiological data to hit a target you otherwise couldn't.
Now, for those CEM-guided procedures, the injection protocol is absolutely critical. There's no room for error here. You must use an iodine contrast agent, concentration between 300 and 370 milligram I per ml. Your dose is 1.22 to 1.5 mLs per kilogram, and the injection rate needs to be a steady 2 to 3 mLs per second. Timing is everything. Your first image acquisition happens precisely at the 2-minute mark post-injection. And remember, that whole procedural window is tight. You need to be done within 7 to 15 minutes to guarantee optimal visualization of the lesion. Let's move on to the standardized procedural workflow. We'll use the stereotactic guided procedure as our base model, since it's the foundation for all 3 techniques. So this algorithm really is the heart of the procedure. It all starts with patient positioning. First, you take a 0-degree scout image just to make sure the lesion is in the window. Next, you acquire your stereotactic images at plus and minus 15 degrees. That's how you'll calculate your target coordinates. Once you've confirmed your target, the workflow splits. You either advance a core needle for a biopsy, or you deploy a guide wire for localization. But no matter which path you take, both end with a mandatory post-procedural verification. That step is non-negotiable. Pay close attention here, because guide wire deployment is a step where things can easily go wrong. The technique is entirely device-specific. For a single hook wire, it's simple. Hold that inner core steady and pull back the outer sheath. But for a double hook wire, it's a 2-step process. First, you advance the inner core about 5 millimeters to deploy that distal hook, confirm your position, then you hold the core steady and withdraw the sheath to deploy the proximal hook. If you mix these up, you're going to get improper anchoring, period. And this distinction, single versus double hook deployment, is something you absolutely have to communicate clearly to the surgeon. Okay, let's talk about what to do when things don't go as planned. We'll cover managing common complications and technical challenges. You need to have protocols in place for these key complications before you even start. The one you'll see most often is the vasovagal reflex. Of course, hemorrhage and hematoma demand immediate management to keep that surgical field clear. Pneumothorax, while rare, is a definite risk with those lesions near the chest wall. And don't forget the other critical risks: infection, potential contrast media reactions if you're doing CEM, and of course, the possibility of procedure failure. Here's a critical technical note, a real pearl for ensuring accuracy. You have to compensate for tissue rebound. When you release that pressure, the tissue is going to spring back. So you must advance the needle an extra 3 to 10 millimeters beyond the calculated target depth. This isn't a mistake, it's a deliberate over-advancement. It's the only way to make sure your biopsy notch or wire anchor ends up exactly where the lesion is. How far you go, 3 millimeters or 10, that comes down to your clinical judgment of the tissue density and skin elasticity.
All right, we're in the final phase now, post-procedure QA and the surgical handoff. This isn't just paperwork, it's what guarantees procedural success and sets up the rest of the team for the best possible patient outcome.
Your procedure isn't finished until you've completed these mandatory QA steps. First, get that specimen to radiography immediately. You have to confirm you've captured the target. Second, the handoff to the surgeon. They need to know the final wire depth, its orientation, and, crucially, the specific wire type you used. And finally, you have to acquire your final orthogonal mammograms, your CC and ML views. This documents the final 3D wire position and serves as the definitive roadmap for the surgeon. So, to sum it all up, the rigorous application of this consensus isn't just about standardizing a technique. It's about standardizing a critical pathway. When we do this correctly, we directly enable earlier, more accurate diagnosis, and that in turn facilitates the precise, tissue-sparing surgical interventions that are key for non-palpable breast cancer. Ultimately, this is all about improving patient outcomes.